Can you see the
I can't see the screen. Send an order again, please.
So I've sent you a request.
Now I have received the request.
Can you see the screen now?
Not yet. I don't know what's the issue here. I allow the sharing screen, Dr. Hassanin.
Just wait then. Yeah. Now, can you see that?
Yes.
So first of all, guys, really sorry for this interruption of electricity is an issue. So again, starting from the same point. So I have summarized the endotamponate agents here. This is the most important endotamponate agent, that is the silicon oil. You can see the oil with its viscosities, specific gravity, physical properties of the silicon oil, indications in which we are using the silicon oil, and the complications associated with it. You can take the picture of this particular slide. It will be very helpful. The most important thing here to keep in mind for the retina fellows is the specific gravity of the oil, which is less than water, and the buoyancy. That is the effect or the endotamponate pressure which it is generating here. This is a table about the gases which we put in the oil. There are three more most important gases like SF6, C2F6, and C3F8. And you can see the properties of those gases in this picture. The most important table or the most important thing is this: how a gas expands, or how it involves three phases: expansion, dissolution. The expansion phase is when the partial pressure of the nitrogen, oxygen, and carbon dioxide in the blood vessel is more as compared to the injected in the cavity. The equilibrium is where the partial pressure of the nitrogen, oxygen, and carbon dioxide in the gas bubble and the blood vessel becomes equal. And the dissolution, in which the gas bubble, the partial pressure of nitrogen, carbon bubble is increased, and it starts sending it to the the third arm or third hand of a surgeon during the surgery. So heavy liquid is the most helpful tool in dermatogenous retinal detachment. I'll show you in some of the videos later. You can take the screenshot of that particular thing. Now I have, Dr. Man, can you see the view
Yeah, I can see the video.
of a posterior vitreous detachment? I have is happening. So the posterior vitreous detachment of you are the it stains the posterior macula, and then I will do the shave. The next thing which I'll like to show you is that whenever you are doing the vitrectomy, the most important thing is that you have to clear the vitreous of the bricks. You can see multiple bricks are present here, and I'm trying to clear the vitreous of those bricks. Once those bricks are cleared off, the retina will be relieved, and because of active oncotic pressure of the retina, it will see in the picture. I have categorically taken out that step to show the importance of clearing the breaks of the vitreous. Once you are sure that the breaks are cleared off, the it is pressing the retina against the choroid, and I am draining the subretinal fluid from those breaks. Now, what is the sign which will tell us that whether the retina is completely settled and the brakes are relieved of traction and there is no fluid? Is the laser marks. Once you are on those brakes or around those brakes, you will see that the reaction would start coming and the retina will take up the direction of those lasers. You can see the laser spots. In the next picture, I have taken small chunk of the part where I am peeling the vitreous PVR. Here I'll show a star fold which is present here and how to uh, do or remove the PVR. This is the most important step. First, you have to stain triamcinolone or BG. Once it is stained, you have to pick from the center of the star fold. Here you can see whole of the fibrous star. Yeah, you can see that. This is the fibrous component which is being uh, getting separated. Again, the same air fluid exchange and then the endotamponade. This is the most important thing. This is I just would like all of you to look at this video and see what's being done here. Well, Dr. Iman, I was intentionally not speaking in this video. I'll show
All
you
right, all right.
again. So this is giant retinal tear here you
Giant,
can see.
yeah,
It
giant
was
tree.
from 8 o'clock to 1 o'clock position. So I started with the vitrectomy. I shaved off vitreous. Then I put in the heavy liquid, which I was talking about. This is the third arm of the patient. With the heavy liquid, whole of the retina was settled. Once the retina was settled, I always try to fill the heavy liquid till the posterior highlight or till the posterior edge of the lens or interior highlight phase. So I completely filled the cavity with the heavy liquid. Once the heavy liquid was feetly attached, I applied the laser all around. And in the end of the surgery, I performed heavy liquid silicone oil exchange. I'll show you. This is, I'm applying the laser. And now these bubbles, you can see the silicone oil, which has started coming into the cavity. And I can see the disc, arterial pulsation starts coming out heavy. This thing heavy liquid. So I the now this is the last video I'd like to show you. This is all. So if I have to summarize this, first of all, the diagnoses of retinal detachment. There are five most important things for rheumatogenic retinal detachment. First, the resident should comment on the PVD, the arc clock of the rheumatogenic retinal detachment, PVR grade, macular status, and the position of the break. And if you talk about the treatment of rheumatogenic retinal detachment, always remember the up to date, the most commonly done treatment is pars plana vitrectomy. The principle of pars plana vitrectomy is that you have to recognize the break, which is the culprit break. You have to clear off the break from its vitreous tractions, and then you have to drain the subretinal fluid. You have to apply the laser around the break, and you have to give an endotamponade. Always remember one thing: it is not the endotamponade which settles the retina. It is surgery which has actually finally which has very thoroughly relieved the retina of its tractions. It is actually responsible for the retina to stabilize and get settled. Retina, through its positive oncotic pressures or positive oncotic forces, gets settled if fractions are removed. Endotamponade is actually a small temporal thing which allows us for the laser to take up its section. About buckling, well, honestly speaking, buckling is not into nowadays procedure. Buckling is selectively done in those cases where phakic is very much anterior to the equator, phakic young patients. Most importantly, in those cases where posterior vitreous detachment hasn't happened as yet. So this was all about the rheumatogenic retinal detachment. I have tried to summarize for the young fellows. I hope um, it's all clear. If you have any question, feel free to ask.
Thanks, Dr. Hassanin, for the very informative presentation. Here we have a question here. Someone is asking, I don't know how to recognize the posterior vitreous detachment on fundoscopy. Someone is asking
So,
here.
Dr.
So,
Iman, I haven't got your question. Could you please repeat your question, please?
some of doctors here asking, I don't know how to recognize the posterior vitreous detachment on fundoscopy. So, do you have
Okay,
specific?
okay.
Yeah.
So you are talking about the clinical examination. So once the RRD patient comes to your clinic, how to recognize the posterior vitreous detachment? The simple thing through which you can recognize the posterior vitreous detachment is the Weiss ring. If the Weiss ring is present, and which would be around the optic disc, if you slightly defocus from the retina into the vitreous cavity, you can see the Weiss ring. If the Weiss ring is evident, it is almost always 90% posterior vitreous detachment is there.
All
In
right.
chronic detachments where the PVR is C and you cannot appreciate the Weiss ring, you can 100% say that the posterior vitreous detachment has happened in those cases. Whereas in early cases, you will very faintly see the vitreous haze, which is because of the RPE cells. But for the vitreous detachment, you have to comment on the Weiss ring, which would be around the optic disc if you slightly defocus it from the retina.
السلام عليكم دكتور إيمان.
Okay, thank you. I
Welcome.
hope Dr. Arwadi answer is clear. أهلا دكتور زهير. How are you?
الحمد لله. I have a question.
Okay.
Why it's important to mention the PVR in RD detachment for rheumatological detachments is different in management or in prognosis or in complications?
Well, could you please repeat the question? I couldn't hear that.
Yeah, he
Why it's
asked why it's important to mention that there is BVR on examination. Well, what's the point? He's asking, Dr.
So,
Zuhair is asking.
this is a very good question. So, recognizing the stage of the PVR, commenting on the PVR is important because it altogether changes your line of action. It changes or it decides how you are supposed to go in, what procedure you are going to do, and what outcomes would you get.
The
So if the
prognostic.
patient is having PVR A, if the patient is having PVR A, B, it's very simple. You can go for the buckling or you can simply go for the pars plana vitrectomy and give an endotamponade. But when a PVR C comes in, you have to exactly identify the star folds. You have to give external approach sometimes, as well as the internal endotamponade, or most of the times, in advanced cases, if the PVR and the retina is not getting settled, you have to do the retinectomies as well.
Yes.
So that is why the recognition of the PVR is very important.
Because it's all about the action and the prognosis as well. Change the action.
Yeah. Yeah.
Okay. Any other question? Dr. Arwa asking it again, is scleral indentation necessary for every patient for rheumatogenic retinal detachment?
Is Claire, sorry, let me see her.
Scleral indentation. Is it necessary for all patients of rheumatogenic retinal detachment?
Very good question.
Yeah.
So the recognition of the break before your surgery is actually the bismillah of your surgery. If you haven't recognized the break and you have dived into the cavity, you are doing the surgery for nothing. Scleral indentation helps us to see the peripheral breaks. In pseudophakic rheumatogenic retinal detachment, most of the breaks are present at the periphery.
Mhm.
While during the surgery, you have to shave off as much vitreous as possible. And for that, scleral indentation is very
Very
important.
important. Right.
Rheumatogenic retinal detachment is a vitreous disease. It is actually not a retinal disease. It is the
Mhm.
pathology in the vitreous. So you have to clear off as much vitreous as you can. For that, indentation is very important. Indentation for the recognition of the break, indentation to shave off the vitreous. In both ways, it is very important.
Okay, thank you. Any further questions? I think there's no more questions. أي حد عنده سؤال شباب؟
So any other question?
Mm. Yeah. In the chat box, is there a possibility for short fellowships at
Is there
the hospital?
Is there a possibility of short fellowship at their hospital? Sure, anytime. Anytime. You just have to walk in. You just have to come here and you will definitely get a chance for that.
All right, thank you.
Anything else? So yeah, there is another
Yeah,
question. The
yes.
textbooks say asymptomatic lattice needs no 360-degree, but practically people do it. Why? Well, Arwa, again, it's an excellent question, and I feel that these are questions from retinal consultants. Usually fellows and residents, they usually hesitate to ask such questions. That's a very beautiful question. Listen, when to laser retina? That's an important issue, and that even can result into a catastrophe. Laser needs to be applied only at those retinas where there is a break having operculum or causing traction at the edges of the break, and a cuff of fluid is present around those break. It is an indication to apply the laser. If the lattice degeneration is there, which is pigmented, never laser it. If the lattice degeneration is there without any pigmentation, again, never laser it. If the lattice degeneration is there with small holes which are partially pigmented, again, never ever try to laser that particular retina. The lattice with big breaks having cuff of fluid, it is an indication to laser. If a fellow eye is having a rheumatogenic retinal eye is having white without pressure, that is an indication to do a laser. Otherwise, laser itself causes iatrogenic breaks to form. Because laser has a tendency to fibrose. Once the fibrosis comes into play, it contracts. It creates small breaks. And once those breaks are created, it will result into a catastrophe of rheumatogenic retinal detachment. So never ever laze retina without any obvious reason. And the obvious reasons I have told two. One, let break with cuff of fluid, fellow eye having rheumatogenic retinal detachment, and the other eye having white without pressure. These are the indications to laze the retina. Otherwise, there is no other indication. Book is right. Don't laze lettuce.
All right. Thanks a lot. That was very informative discussion. An excellent question as well.
Yeah, this was an excellent question. Anything else?
Okay, I think there's no more questions. Thank you very much, Dr. Hassanin, for your time and for your great informative presentation.
Thank you very much, Dr. Iman. Player.
All right. Thanks for all of you for your attendance. Okay. So this is the end of our meeting.